Hello, everyone. Thank you so much for taking the time out of your evening to join us tonight to hear about practical applications of 2.5% polyacrylamide, an imaging perspective presented by Dr. Lea Walker. Dr. Walker is a board-certified specialist in equine sports medicine and rehabilitation. She received her bachelor's degree from Colorado State University and then went on to vet school at Texas A&M. After graduation, she completed a sports medicine and imaging internship and residency at California Equine Orthopedics and now practices at Cave Creek Equine in Phoenix, Arizona. And tonight joining us as well is Dr. Jason Lowe, the Chief Veterinary Officer at Contour Vet, who will be helping moderate our Q&A at the end of this evening's discussion. So as we move through tonight, there is a Q&A box at the bottom panel that you will see. Please feel free to submit your questions as we move forward with tonight's presentation, and we'll answer them at the end. So without further ado, Dr. Walker, take us away.
Awesome. Thank you, Rachel. And thanks for Jason being here as well. So, yeah, I know that Rachel just covered the majority of this, but a little bit about me. I graduated from A&M. I practiced in California for 10 years, came out to Arizona, was fortunate enough to get board certified and take the test in 2021. And thanks to ArthroMed for having us here and have this conversation tonight. At Cave Creek Equine, where I currently work, we have the only 2 board certified sports medicine rehabilitation diplomats in the state of Arizona practicing full time. And we have a lot of diagnostic imaging capabilities, which is kind of why I was invited to have this conversation, because that's really where my wheelhouse is. So we have 2 MRIs. We have a general anesthetized low field magnet, as well as a hallmark standing magnet, nuclear scintigraphy, ultrasound, radiographs, maybe a CT on the horizon, but obviously all of these things take time and money. We have a surgical facility with 2 boarded orthopedic surgeons, a boarded internist, and I'm also fortunate enough to be able to refer cases to Dr. Sherry Johnson with Equine Sports Medicine and Rehabilitation at their Arizona satellite practice. So when it comes to the diagnostic imaging, just as far as a review of really the things that I'm going to talk about tonight, because we have a whole lot of things that are out there, but I have the most access to obviously radiography, ultrasonography, nuclear scintigraphy, and MRI. So those are really going to be the places that we focus. So I just wanted to throw this slide up there at the beginning, because I think that we all take a lot of radiographs, and which one of these things would actually indicate a usage for something like ArthroMed. And so I don't know that my thought process is the right thought process, but I am just going to tell you where it is that I think, and it will hopefully generate a discussion between all of us, because I think that there's probably some nuances that I see that I'm starting to pick up on a little bit earlier that might indicate like, hey, I should start thinking about this. For example, right, a fetlock like this, I saw the soft tissue swelling, but down here at this dorsal aspect of proximal P1, you can see this roughening where the joint capsule actually attaches. And so I do know that there's been some sort of a trauma. I don't see any bony abnormalities that are truly osteoarthritic or degenerative joint, but maybe that joint's going to go that direction. And so this might be an indication where I would say, hey, let's start utilizing something that would stop that process earlier on, rather than trying to play catch up with anti-inflammatories, corticosteroids, et cetera, et cetera. So I just want to start out with a case, because I think that's all what we get interested in talking about are cool things that we've seen. And honestly, I don't know that there's anything really cool about this case other than in retrospect, I would say, hey, you know what? I think that this is a really good candidate for something like ArthroMed Vet, because we didn't have that much on this. So radiographically, this was a 5-year-old quarter horse mare that does Western pleasure. She presented with a bilateral forelimb lameness that was localized to the foot, kind of improved to a PD, took a little bit more of a abaxial to get it to resolve completely, but she did have pretty palpable coffin joint effusion, and radiographs were pretty unremarkable other than the balance issues that you can kind of see. I would have made some changes with the shoeing, but radiographically, there may be just a tiny little spur at the proximal aspect of the coffin bone on the extensor process on that bottom image. But other than that, I didn't really have anything to complain about. And I did take all of the other orthogonal views and didn't see navicular bone pathology or anything like that. I was fortunate enough to be able to have this horse go into the MRI, and some mild to moderate navicular bone edema was identified, but there was nothing really dramatic on this MRI. And I kind of like it when that happens, because that means that I've caught this earlier on in the disease process. But as you can see, you've got this effusive dorsal pouch of the coffin joint. And so, I kind of always expect that when I'm going to go in MRI, but I start to think a little bit more about this, because that effusion and that synovitis is really where this process of degenerative joint disease and osteoarthritis starts. And if we can stop the process there, maybe we're ahead of the curve. So when I started thinking about treatments for Cola, obviously corticosteroid injections, but she's 5 years old. She really hasn't gotten that far into her training yet. And do I really want to start injecting a 5-year-old with corticosteroids, right? Orthobiologics, that's great. And I do think that they have a place in all of this, but really I'm just in there capturing proteins and hopefully trying to reduce some of that synovitis with that. But I haven't really modified the disease per se in utilizing a lot of these orthobiologics. So that's where Arthrimid may have been a better selection for me at the beginning there. Systemic medications, obviously, I think at 5 years old, I'm a little reticent to use that in a 5-year-old, because we really don't have as much data about what it's going to do in the young maturing horse. Then our systemic polyglucosaminoglycans, certainly an option, but it's not going to help just the coffin joint, and that's where she's lame. So what if I didn't have an MRI, right? Where do I go and say, I've got an effusive coffin joint in a horse that's kind of lame and it blocks out to the foot? So which of these treatments, because we have so many of them, but I'm really starting to think a little bit more about using this 2.5% polyacrylamide gel versus reaching for corticosteroids right off the bat. So what information do I use to decide how I'm going to treat that horse? It's really the same in every single case that I come across. What's the history and signalment? What does the physical exam tell me? Is the horse lame? And then utilizing all of those things, figure out what is the most appropriate imaging modality based on where the problem is and what I think might be going on. And all of that is just so that I can come up with the most important thing, which is a diagnosis. Because I think that without an accurate diagnosis, I can't give an accurate prognosis for how successful I'm going to be in this case. And I can't really recommend the most appropriate treatment if I don't know what the problem is. So when I look at my historical and clinical findings, some of the things that might be signals to me to say, hey, I think I have a joint problem, and these are the things that I need to start to consider. Do I have a known joint trauma, right? Is there a performance-related injury, chronic repetitive injury that might make me start thinking, I think that we have a joint issue versus a soft tissue injury or something else? Or do I have a known surgical intervention? Is this iatrogenic? And now I'm on the back end of that trying to say, okay, I know what the problem is in that joint, and now I'm going to help try to fix it in other ways besides just what the surgery did. On my physical examination, I think that sensitivity to flexion is actually really an indicator for me, because I think that sensitivity to static flexion, that really, when you stress a joint and the horse reacts to that, that tells me that there is an active process that's happening, and may not have anything to do with the joint, maybe something else, but I certainly think about it because that's kind of a big red flag, as well as joint effusion. And then obviously lameness. Do I have lameness in association with that limb that I have identified on my physical examination? And then clearly what we're here to talk about tonight, right, which is the imaging findings. So which of those diagnoses or differentials actually constitute treatment with a 2.5% polyacrylamide? So this probably isn't an all-inclusive list, right? But for me, I break things down as simple as I can. And really, I'd be thinking, degenerative joint disease or osteoarthritis, and synovitis. And are there other diagnoses that may be related to that DJD, OA, or synovitis condition? So do I have an injury to a periarticular structure that might be inciting inflammation within that joint, that maybe the joint inflammation isn't the primary thing, but I still have to think about it because that's still something that might be pertinent to this horse's future, right? So I think a lot of us are familiar with this very intense figure describing the process of degenerative joint disease and osteoarthritis. And one of the most, common things thinking of going back to vet school is, okay, well, you can have loss of articular cartilage and exposed subchondral bone and all of that damage that has occurred, leading to this negative cycle of inflammation within the joint. And really, that is part of the problem, and it's important, but it's not really the target for what we're talking about tonight. The target for tonight has much more to do with this synovitis part of it. So the synovial membrane, we're going to get into a little bit more because that is a really active part of this disease process. So and these next few slides are actually reproduced thanks to Dr. Meg Green, who is the Contura Vet Director of Veterinary Services. And so she gave me these slides so that I can kind of just go through a lot of that, and then we're going to get into the imaging. So the synovial membrane encloses the synovial cavity, but it has a lot of important tasks, right? It regulates the composition of the synovial fluid and the homeostasis of the joint. And it's essential for the lubrication of normal joint, which reduces friction and nourishes the cartilage, right? So we have to have healthy synoviocytes to produce healthy synovial fluid so that the joint is properly lubricated and the cartilage is healthy. Lubricin and HA do help in that to protect and support the function of that cartilage. Anatomically, there's really two big areas. I'm concerned about the intimal layer and the subintimal layer. And that intimal layer consists of three different types of cells, A, B, and C, which are macrophages, fibroblasts, and then the intermediary cells. And then going back to immunology, right? Macrophages are really responsible for phagocytosis, which is also important and pertinent to tonight's discussion. So histologically, when we look at that intimal layer of synoviocytes, obviously that's the cell layer that's right up there, all of those cells that are producing the healthy synovial fluid. And then underneath that, in this subintima with the fibrous tissue and the blood vessels, that area is also helpful and necessary to help the health of the intimal layer. So the synovial membrane can, if it's irritated, it can also release these pro-inflammatory and catabolic molecules, and those factors upregulate the expression of MMPs, which we all know is involved in the breakdown of healthy cartilage, and therefore this whole negative cycle of osteoarthritis. So those macrophages are a key component to the immune system and control and regulate normal joint function. And so they will engulf foreign bodies within the joint cavity. They interact with the synovial fibroblasts, and they are crucial for joint homeostasis. So when there is inflammation within that joint, the regulatory functions will become overwhelmed. Another key component to this side of it. So IL-10 is a potent anti-inflammatory cytokine, and the presence in the joint helps to resolve synovitis. So when these IL-10 expressing macrophages are present in the joint, the negative feedback loop that incites this cycle of DJD or OA, that loop gets broken. So the key takeaways just from that part of it is that our aim is to resolve inflammation early. The synovial macrophages play a role in maintaining the joint homeostasis, and less inflammation over time is going to result in less insult to the joint and the structures within the joint. So the reason that's important is because we need to know the mechanism of action and the target tissue for the medication that we're talking about tonight. So it recreates the cushion, it rejuvenates the synovium to improve the nature of the synovial fluid so that we have better joint function. Outside of knowing mechanism of action, I think that it's also really important for us to feel confident in the safety profile, right? So for me, this was kind of a big light bulb moment, because recognizing that all 4 of these medications that are on the screen, arthrosamid, bulkamid, aquamid, and arthramid vet, it's all the same product. It's all a 2.5% polyacrylamide gel. And so we've had aquamid out on the market since 2001, and it's been put into humans since 2001. And so I believe that if there were some safety concerns about this, or changes to tissues that we weren't expecting, information about that would have come out already. And so just knowing how long this product has been on the market and how much research has been put behind it makes me feel very confident in the safety profile, so I don't get nervous when I'm putting it into a joint of a horse. Now, not only do we have the past data, but we have data that's coming out currently, right? So in this JAVMA study from 2024, Dr. Lowe confirms that this intra-articular injection induces a low-level foreign body response, which is predominantly macrophage driven, and there is no evidence of fibrosis or mineralization. So all of those things really important to me, right? I don't want any fibrosis within the joint with the joint capsule, or any mineralization. And so that's great. We're actually getting data, true good clinical data, to suggest that. In that study, the inflammation that was macrophage driven showed no evidence of neutrophilic inflammation, which is important. No fibrin deposition, no mineralization, cell death, or any other inflammatory cell types. And obviously, Dr. Lowe being the author, he's here and can certainly answer any additional questions anyone might have about this at the end of the discussion. So it doesn't just stop there, because we are not only interested in where we've been, but what's the plan? Where are we going from here, right? And so the current things that are kind of coming down the pipeline, CSU just commenced this study, July 2024, so just last month. And the primary purpose of this study, being performed with Doctors Contino, Seabaugh, and King, is to study and test the efficacy of this hydrogel after intra-articular injection through the carpal chip model, which is obviously a really well-defined it's been in a lot of studies, right? The secondary purpose then would be to define the mechanism of action, which I think that we're all also interested in. Other components of that I think are really kind of exciting is that they're using lameness exams that have AI technology. We're doing kinematic and kinematic gait analysis. So there's a lot that's going to be happening within that study that I think is really exciting. Not only are we doing these things on the equine side, but our canine counterparts are also going to be taking on some of the research efforts. And so Dr. Matt Brunke is the primary investigator for this study. And the objective here is going to be evaluate the effects of arthramid vet in dogs' elbows with osteoarthritis. And this was approved 2023. Enrollment started in November, and we now have 75% of those dogs. So I'm excited to get some data back on these dogs. Okay, so really the part that I was invited here to talk about is what are the imaging indications and diagnoses as I see it in the imaging side of things that I do. So radiographically, obviously, if I'm thinking about synovitis, DJD, osteoarthritis, radiographically, I'll see osteophytes or enthesiophytes, narrow joint space. And I also do look for that soft tissue profile, like we had talked about on that very first slide, right? Ultrasonographically, also looking at those osteophytes and enthesophytes, I can see reduced thickness of the articular cartilage, and looking at joint effusion and synovitis. And I think that that's something that we'll dive into a little bit more, because I think it's really important to be looking for effusive joints and defining what synovitis truly looks like, right? And then MRI, obviously you can see all of those things, but the two other parts of that I think MRI is really helpful to see is subchondral bone injury, and then any other periarticular soft tissue capsular component to that injury. Nuclear scintigraphy, I'm a big fan of bone scans. I think a lot of people here know that, but that for me isn't really a standalone indicator for treatment, just because we're not really looking at the joint in itself. And so we may see enthesius uptake around that joint, but I'm still going to be doing other things that would say this joint warrants therapy with X, Y, or Z, right? So radiographically, some of the markers of joint disease that we just talked about, collapse of a joint. So I find the pastern joint to be one that's really difficult. And so when I see something like this, I know without any other imaging that I do have loss of cartilage in there. This process of osteoarthritis has well begun. And so this is certainly an indicator for me. Enthesiophytes and osteophytes. And I know that this kind of goes back to second year vet school, but I think it's kind of important to identify the difference between the osteophyte and the enthesiophyte, right? Because an enthesiophyte is actually a bony outgrowth at the attachment of a soft tissue onto bone that then grows in the direction of the natural pull of that soft tissue. Whereas an osteophyte is actually a bony outgrowth on the articular margin associated with degeneration of cartilage and joints. Both of these things can be involved in the process, but I do get concerned about enthesiophytes, because if it is at a joint capsule attachment, I might have joint capsular involvement, and that may just be the start, just like that first fetlock, that might be the start of this osteoarthritic problem. And then, these osteophytes that you see at these articular margins are pretty good indicators, obviously. But if we look, because it's not just those big obvious ones, right? So I don't know if anybody had attended this, there was a session at AEP this last year with the radiologist, and it was like, ask your radiologist questions. And one of the most common questions that I think they got had to do with this kind of fluffy proliferative bone, or this really dense appearance of the dorsal cortex of P2. And Dr. Myra Barrett's comment was, when I see that, then I know that there's a bad guy in that coffin joint, because that coffin joint pouch, that dorsal joint pouch, actually extends almost all the way up the entire face of dorsal P2. And if you see a little hook up at the top, then we know, like, maybe I can turn this on. So if you guys can see right here, obviously you've got this proliferative bone, but sometimes you'll even see a hook right here. And that might mean that there's actually this really kind of significant synovitis or capsulitis associated with the coffin joint. And I would be digging a little bit deeper to find that bad guy, right? So, I mean, that horse was like a 2+ out of 5 lane. This horse was 4 out of 5. And so I can't always just rely on the severity of my radiographic problem to say, oh gosh, this is going to be a bad one, right? Because obviously in this horse, I have a little osteophyte right here, but it isn't down the street and around the corner with how much proliferative bone I have. So, how then do I decide? And obviously advanced imaging is really helpful, but we don't always have that in every case. So the things that I think about is, if I see a radiographic change, how long does that mean that the joint disease has been present for? Because I know that it takes at least 3 weeks for bony proliferation to form. So I know it's been going on for at least 3 weeks, but it probably started even before that. And maybe it started with the synovitis. So outside of, okay, well, I know that this has been going on for a while. It also makes me wonder, how successful am I going to be in this therapy? And is it going to require just a one-time treatment and I get resolution? Or is it going to require multiple injections? Or is it going to require adjunctive therapies, right? Um, as far as the usage of Arthrimid, I would say I personally will wait about 6 weeks before administering a second dose, because I know that it takes a period of time for that 2.5% polyacrylamide to be integrated into the subintimal layers of the synovial lining, and then the production of synoviocytes and that healthy synovial lining, and then pumping out healthy synovial fluid. So I'm going to give it time before I really make a decision on how efficacious my therapy was. I obviously don't want to just do that one view and make a decision off of it. This is the reason that that other horse was so lame, and this isn't actually her radiograph, but I am hoping that y'all can see how significant of a joint collapse of the coffin joint here was. And so that's why she was lame. And so I don't know that that had been going on for an extraordinary period of time, because she didn't have that much periarticular remodeling, but MRI in her case really did confirm that she had cartilage loss, and that's why she was so lame. Unfortunately, I would love to catch this before that happens, because once I've had loss of articular cartilage, I already know that that's going to be harder. I think we all know that, right? And so I want to identify those things as early on as I can, so that I can institute therapy and hopefully stop the process, reverse it if at all possible, but at least stop the process. Okay, so ultrasonographic markers of joint disease, and I think that this is probably a little bit more of where we can start thinking about this specific product, because ultrasonographically, I think that we don't, outside of the mediofemoral joint, which you can see down here on the right side, this is a pretty proliferative synovitis within this mediofemoral joint and pretty effusive. Right. So I can identify how much effusion is there, and I can see how much synovitis and proliferation of the joint capsule there is, but we can see it in other places too. And so, for example, this fetlock, right? Remember that palmar pouch of the fetlock is interposed right between the metacarpus metatarsus and the suspensory branch. And so we should be looking at that too. I know that I'm sitting there scanning the branches. I don't have to move my probe at all, but I've started to take a whole lot more note, because this one was effusive, but it didn't have a whole lot of junk in it. It was just effusive. But I think that we've all seen that, and it's just like this squishy, fluffy material. And I think about that now, because I think that identifying it and saying, hey, if I'm going to treat this, can I recheck that and make it look better? Okay. Now, outside of just looking for that synovitis, I'll also be looking for these other markers of joint disease. So the osteophytes or enthesiophytes. I hope that some of you are all doing this as well, but actually taking these stifles and putting them into flexion and looking at the articular cartilage, right? So articular cartilage is made up of 99% water, so it should be black on an ultrasound, and looking at cartilage thickness and looking at the integrity of the cartilage. So as you can see here, you've got this hyperechoic area within the articular cartilage of the medial femoral condyle. And so it shouldn't be white. It should, and you have actually some subchondral bone irregularity underneath that. And so there's some scar tissue in that cartilage. So it isn't complete cartilage loss, but there's some scar tissue in there. And it's good to know, because maybe I can, again, identify that process happening earlier. This is actually the same exact horse, and she didn't have a terribly effusive joint. She had a little bit of an osteophyte here. The meniscus looked okay, but she did have some fibrosis within that medial femoral condyle. So she certainly would be a candidate in my eyes. This is just that same horse in a dynamic scan. And so you really have to get down there, and you would initially think like, oh man, I think it looks okay. But you really have to get up underneath, because it is going to be the weight-bearing surface of that condyle that you're going to be able to find that. And so, you know, maybe that's all that there is, but that would be great if that's all there is, because I haven't gotten cartilage loss yet. It's just scarred. I can also ultrasound the articular cartilage on a fetlock condyle. So again, you have to pull it into flexion so that you can look at the weight-bearing surface. And this is the right front fetlock. And so you can see this very thin, I know that the slide might be kind of small, but you can see this very thin articular cartilaginous layer. And here's the left front inflection. And first of all, you can see some irregularity of the subchondral bone layer. You can see thickening of the joint capsule here. There's probably some synovial proliferation within that. It's in flexion, so it's tight, and you can't actually see the synovial lining in and of itself right there. But you can look at the sagittal ridge and identify that cartilage thickness there, and you lose it going over the medial condyle. This is a video of that horse. And what's interesting to note on this, see if I can make it start over again, is that spot right there is actually an osteophyte. So when you see that osteophyte on proximal P1, that osteophyte is almost always covering over the area of cartilage loss and subchondral bone damage. And so that's a huge red flag for me when I see that spur on proximal P1, because I get a little bit worried that maybe we do have some cartilage loss on the medial condyle. So of course I had taken some radiographs, and I didn't put the oblique up here, but there is the osteophyte. We've got a little osteochondral fragment in there. You've got this roughening, and you can see actually up here at the enthesis of the joint capsule insertion. So there's enthesius remodeling. There's an osteophyte with a fragment. This wasn't the greatest DP, but you can see that there's this lucency right here. And then I will, if I'm worried about this horse was 3 out of 5 lame, but I crippled her with flexion. So when I flexed on her fetlock, she would go non-weight bearing for about 4 steps. And this view is really helpful because this is her right front fetlock. Here's her left front fetlock. And you can actually see this radiolucent area in the medial condyle that is not there on the right front. So what this means to me is, can we actually identify this earlier? Obviously that fetlock case, there was already radiographic change, right? But can we actually see that we have some scarring within that articular cartilage? Can we see the synovial proliferation and the joint effusion? And if we can identify that, can we actually make some benchmarks? And we don't have that right now. You know, we're always kind of looking for the next new things. And I think that it's really important. The more we start looking into it, the more likely we are to be able to figure out, hey, this is something that I keep seeing. And every time I see that, it means that this joint is dealing with this. So in that, maybe we can identify the disease process earlier, but I would love everybody's help in coming up with some benchmarks that we could help identify what that synovitis or synovial proliferation really means and what's normal and what's abnormal. But then does every horse with joint effusion or synovitis warrant therapy with arthromid? I don't know. But I think that this is at least where the conversation starts, right? So I think we first of all need to have a thorough examination and localization of that injury so that we can do the appropriate diagnostic imaging. That way we have an accurate diagnosis to identify what the problem is, the degree of the pathology, what is the prognosis, and then we can target our treatment and a rehabilitation to that, right? So it isn't for me, and this may be just like a separate soapbox for another day, but it isn't just about the targeted treatment and what I'm going to put into the joint. It's about what I do with that joint after I do the treatment, right? Because we can't blame treatment failure on a product if we don't do the things to help the rest of the body heal with it, right? So if I have a terribly arthritic joint, clearly that fetlock horse, super sensitive to fetlock flexion, and she had reduced range of motion. So if I go and I put something in there and then I don't rehabilitate that horse properly and put her into some passive range of motion exercises and try to reduce the amount of joint capsulitis and constriction that I have, I'm probably not going to get anywhere. Maybe I wouldn't get anywhere in the first place because it's a pretty bad injury. But I still think that rehabilitation needs to be an important conversation when we talk about any therapy that we institute. Okay, so as far as the advanced diagnostic imaging is concerned, MRI is really the only one that I'm going to talk about tonight. We can see all of those same things that we can see radiographically and ultrasonographically. So between the enthesiophytes, osteophytes, synovitis, joint effusion, thinning of the cartilage. But for me, the subchondral bone injuries are important to talk about, and so are the periarticular soft tissue injuries. And the reason for that is I think that if you have a subchondral bone injury, right, this horse that has a bone bruise of the dorsal distal aspect of P2, if that was a concussive injury that happened and the process of osteoarthritis starts here in the subchondral bone, you're still going to have the process incited at some point. And so you will end up having a synovitis, right? You will end up having watery joint fluid, and it may not have started with the synovitis, but we still are going to have a synovitis to contend with. So I think it's still important to think about it no matter where the process starts. And so in this horse, clearly we have the bone bruise, but there is also effusion and synovitis within that dorsal pouch of the coffin joint. I feel the same way about periarticular soft tissue injuries, right? So this is an image of a collateral ligament injury within the distal interphalangeal joint. And I think it is important to recognize that those periarticular structures, not only do they have a direct effect on the joint capsule and the synovium because of the proximity, right? They sit that close, just like a horse that has a suspensory branch injury will oftentimes have some degree of inflammation within the fetlock joint, right? So I think that we can't forget about those periarticular soft tissue injuries having an effect on the joint, but they also affect joint stability. So in the case of a collateral ligament, if we have microinstability that may be tugging on the joint capsule or the synovium or irritating the subchondral bone or the articular cartilage, again, the process is starting, and that's where I'd like to catch it so that it doesn't progress. This was an interesting case of a horse that had a really significant injury down here to the impar ligament. And so I knew that once I got done with the MRI, I said, oh, okay, well, this is like a very obvious injury down here. But there's also an osteophyte that has been produced at the dorsal aspect, and that's clearly far away, but I know that I have joint inflammation associated with it. So thinking about how to contend with that overall joint inflammation in injuries of structures that may be associated with the joint, but not directly related to the primary injury. Right? And then some other kind of unconventional locations that I have put arthromid. So this was a coxofemoral joint of an upper level jumper that was no longer upper level. And you can see on that left side of the screen, that left hip has some pretty significant periarticular osteophytes. There's thickening of the joint capsule there. I sometimes find these really difficult to treat because I like to think that I know exactly which break in between those osteophytes is the joint that I'm targeting, but that can actually be a really big challenge. And so getting down into that joint and knowing that I'm in the joint was a little bit challenging on him. I will sometimes inject just some saline in there and see if I can put it in there and get it back out. But you kind of have to put a lot of saline in there to do that first. And treatment in this horse was actually successful for what it was that they were looking for. This is pretty advanced disease, and he had some pretty significant muscle atrophy and all of that. But he's pasture happy, and he runs around and enjoys it. And he comes in every 6 to 8 months, and the owner is asking me to re-inject the gel because he has responded so favorably when it comes to his his overall demeanor and his quality of life. And so even though he's not a jumper, I still find that to be a case success because I think that it's keeping him happy. And then another unconventional location that I don't have as much usage of just because it hasn't been in my caseload yet, but I have a lot of colleagues who have used this very successfully in cervical facets. And we can't forget, right? Those cervical facets do have a joint capsule. They're obviously not a load-bearing joint, but they do have articular cartilage and they do become arthritic. And so using this to try to stop the process of osteoarthritis here, I think makes a whole lot of sense. Obviously the cervical spine, but then I have also treated an elbow as of recent, and that actually was pretty successful there at the beginning. He has a pretty high demand on him, and unfortunately he wasn't sound for long enough, and he just ended up having surgery on his elbow recently. So we'll see how that goes, and maybe he's a candidate for post-operative treatment with polyacrylamide gel. So that being said, I wanted to leave quite a bit of time for discussion and questions because I think that's what makes webinars hard, is that I would love to be able to be face to face with everybody here so that we can have a conversation over a cup of coffee or a glass of wine. But since we are not, we can do that here, and we're happy to answer any questions and have any amount of discussion that you guys are up for.
Thanks, Leah. That was that's amazing. You made some really good points in there, and certainly quite a mix of cases and a lot of really cool diagnostics, which is really the answer, isn't it? Like you say, just being able to cut in and get an accurate diagnosis.
Yes.
I really liked your comments there too around that, just the importance of physical exams. I know when I sort of, in some of my other roles, coaching students and that, I still come back to, using your eyes and your ears and your hands to, trust your clinical judgment, because so many cases are so different. There's lots of other factors going on, isn't there, as far as the expectations of the horse and the owner and the management and the surfaces and et cetera, et cetera. So,
and I think a good clinical examination is the first thing, right? Imaging is never the number one and first thing. So I know this kind of conversation has started with imaging, but it really is about that clinical exam of where is it going to jump off from there, right?
Yeah, absolutely. Hey, we've had some questions come through. I guess to answer a few quickly, there's somebody asked, have you used this in a carpal sheath?
So I have not, and not because I haven't wanted to. Honestly, I don't have as many carpal sheath. I know that Dr. Bo Whitaker, has used this quite extensively in the digital flexor tendon sheath. So maybe you can speak to that. I haven't used it in a carpal sheath yet, but I don't see any reason that it would be contraindicated.
Yeah, I'd agree. It's a synovial structure. I guess it's a really rare area. I think I've probably only seen one or two injuries there in my career. Again, probably not contraindicated, but they do tend to respond pretty well to other treatments too, don't they, as far as conservative management and maybe putting the scope in there to clean some bits out. I guess depending if you've got a nasty accessory carpal bone fracture, which is causing the issue.
Again, it's all about the diagnosis, right? Is the diagnosis going to fit the therapy?
Yeah, that's right. Someone asked there about sacroiliac joints, but just to say, this product isn't indicated for sacroiliac joints. SI joints in humans are synovial joints, but they're not in horses, so I wouldn't be putting it into sacroiliac joints. What else have we got here?
So I'm gonna, Dr. Brunke had actually commented on the elbow joint, and I think that's really important because obviously a dog elbow joint is slightly smaller than the horse elbow joint, right? I think that dosage of this product is something that we're still really trying to elucidate, right? So we've got, there's several questions it looks to me like we have about dosing. And so maybe you'll be able to help with this as well. Honestly, I only had the latitude to inject one syringe into this horse's elbow. And I would tell you that I think that I may have had an effect. We did a whole lot of things to get this horse capable of showing. And so I can't say that, oh, wow, it was just that one syringe of Arthromid. Had I been able to put 2 or maybe even 3, because that is a massive joint, right? And if we think about the mechanism of action of this product, and the target tissue, that synovium has such a vast surface area that I think that it would probably be appropriate to use more. Would you agree?
Yeah, I would agree in a case like that. Like you say, importantly, you can't do dose titration studies on this product because it's not a pharmaceutical drug. It's just got this physical effect. I sort of divide my cases into mild, moderate, severe, and I certainly see in very early stage OA, fetlocks, knees, we're getting great results with 1 mil. And I tend to, like I say, do mild, moderate, severe disease, 1, 2, or 3 mils. So if I had I guess like your elbow or your hip case there, it's one chance, isn't it, to try and salvage that horse. So I think get as much in as you can, and that the owner's budget will allow, but because I think there's probably a dose dependent effect on it. But again, if we're getting more and more proactive around early identification of joint disease and early treatment, you can drop your dosages back. I think that sort of segues into another comment someone asked there about they said they'd had more issues putting 2 mils into a fetlock joint compared to 1 ml. I haven't seen that myself clinically, but I do sort of have this mantra that I don't put it into an angry joint, if that makes sense. We deal with a lot of racing thoroughbreds in Australia, New Zealand, and some of these horses come lame off the gallops, and I'll give those horses a bit of time, maybe even still use some cortisone just to settle the joint down, and then come in with the Arthromid afterwards.
I think I tend to do that a little bit. That leads to kind of one of these other questions, right? About combinations of therapies, right?
Yeah.
And I think it's still a little bit of the Wild West out there. And I think that people are doing all of the above, right? They're combining syringes, they're doing it in tandem, they're waiting. And so all I can tell you is I'm just a little bit more academic. I like to know what is the change that I've made with this one thing, and then go from there. And I think at least, and correct me if I'm wrong, but the evidence in your research has actually shown that corticosteroids may not be the right thing to do at the same time, right? Because of the immune-mediated response that we're looking for here. Would I be right in saying that?
Yeah, that's right. It's sort of counterintuitive. We know the cortisone will suppress that macrophage-driven response. There's evidence around it delays fibroblast migration, things like that. So yeah, it's just counterintuitive, and I agree. And I love in your talk there where you talked about, to me, treatment is half of what we do. The rest is how we manage and rehabilitate the horse. And I'm not a big fan of this sort of treat and keep working these horses. If these horses are lame, they're lame for a reason, and we need to back off them. And that's again what I love about this product, that it actually gives you something to put in, spend a little bit of time, give it 4 or 6 weeks on a rehab program, come back and re-examine it. Do we then give it a top-up dose? Do we need to add something else into the treatment regime? And of course with feet, which very common issue with coffin joint lameness. Again, you want to go through 2 or 3 shoeing cycles before you've corrected that balance and sorted those other things out. So
Yep. Because you can't blame it on what it is that you've used to treat if you haven't taken care of all of the other things that surround the problem, right?
Yeah, absolutely. I think, to go back a little bit, the treatment around flexor tendon sheaths, we have had great success treating that structure with this product. And I think, again, when you look at the literature, a lot of those are Manica tears or defects in the paratenon of the deep digital flexor tendon. And I do believe that this product is truly scaffolding and just helping those defects heal in, or at least it's sort of protecting those areas from that synovial environment, which we know delays healing. So yeah, I don't right now to put it into those structures and see really good results, because I found, again, with cortisone or time, they just flare up again, or once the drugs wear off, we've had much better long-term results using this.
Yeah. How long do you wait between if you elect to do adjunctive therapies, because you have a really bad synovitis, or you want to use orthobiologics for some reason? How long do you wait between that and Arthromed?
Yeah, great question. 2 weeks, basically. I'll post-surgery, I'll wait 2 weeks. Yeah, if I've used something else, I'll either, when I can, I'll start with Arthromed, and then, like I say, go back usually 2 to 4 weeks later, recheck them and decide if we're going to use something else as well. But I like your point around waiting a good 4 to 6 weeks before you really assess that treatment outcome with the Arthromed.
Yeah.
But yeah, if 2 weeks either side, and like you say, I think combination treatments, but it's really coming back to those great slides that you showed there from the joint lameness book and McElwaith's work and stuff. It's understanding what's happening, in the synovium and the articular environment, the subchondral bone, and then ultimately in the cartilage. But like you say, cartilage is very end stage. Once we've got cartilage damage, I don't think we can really do much at all.
Right. And so how if we are at that end stage and you're just trying to maintain comfort, kind of like that hip, how often do you think that we can repeat Arthromed joint injections?
Yeah, look, I just don't. I think I say indefinitely. I don't want to be flippant about it, because I think you base it on your clinical signs, but we certainly repeat dose 6 to 12 months in some of our racing horses. We're probably doing 1 to 2 years in our high-level performance horses. And I think, in our safety studies, we did 5 times the dose. I don't think there's any concerns around repeating dosages and that this product somehow builds up in the system or something, because it's such a tiny microscopic amount of active that we're putting into these really large structures. And I think, again, when you go back to some of the human data, see the arthrosamid in humans, they're using 6 mil into a human stifle joint, which I find, that's really high to me when I get a great result with 1 mil in a 500-kilo racehorse. So I'm not, but I believe it's possibly because human OA is a much later disease. We're not being that proactive around it now because we haven't had a product like this available to treat it. So
Yeah.
So it'll be interesting.
And they're just trying to get that human past the age of 70 so that they can do a knee replacement versus, okay, well, I'd like to actually go out and run another marathon, right?
Yeah, exactly. I think, and even we've seen that shift in our clients from, again, the early research work around Arthromed was end stage cases. They'd been non-responsive to anything else. So let's give this a go. And the results were still pretty spectacular. But over the sort of 6, 7, 8 years I've been working with it now with our clients, we're just much, much more proactive, doing it much earlier on in the disease process. Seeing those better long-term results. So someone's asked there about, post-fracture, a P3 fracture. Again, I think you just got to give, if you've got an intra-articular fracture or fragment, you've got to obviously deal with that, let that fracture heal up, and then put the Arthromed. I'll be using the Arthromed later on, so perhaps a couple of months or 3 months afterwards. Is it okay to add amikacin when injecting a joint? Look, I think Bo Whitaker, as you sort of referred to before, he presented a AAEP last year around using both together. And basically, there's also some retrospective data out of the UK, which is unpublished, and a lot of that was combination therapy. I think what it showed us was it didn't make any difference. So I think it's okay to do, but as we said before, I think just really try and understand why are you doing it. For me, it's just counterintuitive. I'd rather use one or the other and come back in a couple of weeks and have another look.
Yeah. I saw in here that someone had asked about amikacin. I don't remember where I see it, but honestly, I don't know if it's okay or not. I have moved away from it just because honestly, I feel like I've got a pretty clean environment and I'm trying to not do anything that is going to incite a problem with the cartilage. So I don't tend to use amikacin, but I also will fully admit that I'm in an environment where it's nice and clean and it's not dusty and I'm not in an aisleway. So I don't know, have you had any experience? Is there any reason to not use amikacin with it?
Look, I think again, when you look at the published research, there's no need to use amikacin. Putting antibiotics with your joint injections, it makes no difference. And in fact, I think it could be harmful. I think if you do it, dropping your doses with these aminoglycosides, and there's some good work out of CSU with Lynn Pezzanite and et al. that researched on that. But to me, it's acidic, right? It's a really low pH aminoglycosides, and I think to me it's just irritant into the joint, and then we're putting this foreign body, this polyacrylamide there, which induces this very low grade, foreign body response. But I don't want to put anything else in there that's going to complicate that.
Right.
And so it's sterile. The manufacturing on this is unbelievable. The state of the art. It's human grade. I think all those.
And let's be real, when you go to the human orthopedist and they put something into your joint, they're like, let me give you a little betadine scrub, wipe it with alcohol and put the needle in, right? And granted, we're not rolling around in a stall of shavings and manure, but still, we've gotten very conditioned to being concerned about joint infection. And so I get being gun shy, but I don't use it, and maybe we can move away from it.
Yeah, 100%. And again, when I sort of talk to young vets, I always, because it's nerve-wracking, right? And you you put yourself in these different situations, but to me, control your environment. In New Zealand, we actually have a health and safety responsibility to control the environment. For the owner, keep them safe, keep yourself safe is number one. And I pretty much don't use this unless I've sedated the horse and controlled the environment. So you get a nice clean injection technique. We use I'll always have a nurse with me to help, just hold stuff and make sure that it's clean and you stay sterile. So.
Yep, absolutely. Someone asked a good question about seeing susceptibility artifact on MRI post-treatment. And I know that I have had horses that have been treated that I have done MRIs on, and I have never seen susceptibility artifact. I have seen susceptibility artifact just secondary to, if you had a bleed in the coronary band, so you can see some of that hemosiderin in the dorsal pouch of the coffin joint. But I can't tell you that I've seen any artifact associated with actual that I could identify as this was arthromed. Anything that's come across your desk?
No, I certainly haven't seen anything like that. So yeah. There's a lot of questions coming in.
There's a lot of questions.
I'm not sure, Rachel, if you want to just keep us going, or we're on time because we're an hour now.
And I mean, honestly, I'm always happy to talk to people, and my email address is on the Cave Creek Equine website, and so is my cell phone. So you can call me, and the people on here that know me know that I'm more than happy to talk. And my husband will attest to it too. I'm a talker.
Yeah, look, I'm the same too. I just think, to me, it's about education, understanding the product. I guess one of the early questions there about the the advantages of 2.5% over a 4%. Have you comment to that, Leah? What's your
So yeah, I mean, we carry both products in our clinic. And really the proposed mechanism of action of Nultrex is different. They say that it binds to fibrillated cartilage or exposed subchondral bone. And I think that we're still waiting on some more in vivo data to support that. But honestly, most of the time, if it is end stage collapse of the joint and I know that I have loss of the articular cartilage, I kind of leave it up to whoever the referring clinician is and what they would like. But I don't have a good answer for that. And I can't tell you that I see any clinical data in my experience that I can say, oh, wow, well, in this case, this worked way better than that, or vice versa.
Yeah. I think the key to me is understanding that they are very different. Like you say, I think the in vitro study that sort of reported that it covered cartilage defects, I think we have to be very, very careful how we interpret that data, and I'd love to see that repeated in vivo, because if it does do that, it's pretty much the holy grail, and human orthopods would be all over it because that's a massive issue in sports athletes.
Yeah, resurfacing a joint, right?
Yep. So, and I think other than that, when you do the analysis on the different studies, and Aziz Nibar did a great review article published in Jev's last year or the year before, I think it was, and looking at the safety profile on the 2.5%, it's the most biocompatible, and there's a lot of technology around that. The stability of the product because of the way it's manufactured with the cross-linking of those strands, so it doesn't degrade. Polyacrylamides you don't want to degrade because they degrade into acrylamides, and acrylamides are highly toxic, neurotoxic particles. So that would concern me. And again, I think the efficacy, again published paper on the 4% showed a reduction in one lameness grade, and that to me, whereas all the 2.5% studies have looked at a complete resolution of lameness, and that's what my clients have always thanked me for, is making their horses sound not slightly better.
Yeah. And honestly, I want to speak to that because I was coming up with this presentation and I was like, as an imager, I like to see things resolve, right? And I didn't put any of those cases up because I don't know that the things that I'm seeing are as important on a screen are as important as the things that I'm seeing clinically, right? And so it's the clinical resolution of the lameness that I think has been a little bit more substantial when it comes to case success, right? Because I'm not going to change the radiograph, right?
Yeah.
I'm not expecting to resolve that subchondral bone edema with an injection of arthromin. So I didn't put any cases up for that reason, because it's really about having a lame horse and having a sound horse. And we've all seen that. So I wanted to focus the discussion a little bit more around that side of things. But just so you know what I'm thinking when it comes to case success on these, it isn't a resolution on an image, right?
Yeah, and I agree, and I think you did that really well in your presentation, because and even scintigraphy, right? It's highly sensitive, but very non-specific. Radiographs are very specific, but very non-sensitive. And we always have a saying here: horses don't run on their X-rays. And I think we've all seen those horses with terrible X-rays, which keep competing and doing amazing stuff. So,
yeah.
Well, thank you, Dr. Walker and Dr. Lowe, for sharing your expertise and experience. We really appreciate it. This has been really insightful, and thank you all of you guys for taking time out of your evenings to attend this. I know we had a lot of questions come in tonight and we didn't quite get to all of them. So our next webinar is on Monday, September 23rd. So please feel free to attend that and you can get more of your questions answered that we didn't have time to today. And like Dr. Walker so generously offered, you can reach out to her directly as well as us here. So thank you all for your time tonight. We really appreciate it and have a wonderful rest of your evening.
Thanks, everybody.
Thanks, everybody. Thank you, Leah. You'll push end now, will you? Cut them
I
off.
don't know that I know how to do that. Stop.
Stop. There you go. You did it.
Did I do that?
I hope so.
We're still recording. Hold on.